Hi there, my name's Justin Chu. I'm the Medical Director here at TFP Oxford, and I just wanted to welcome you to the Ask the Expert episode, which is going to form a longer series. We've had patients sending in questions to us through social media, and I'm hopefully going to be able to provide some advice. So the first question that I've got from a patient from social media is, when is the best time to have an antral follicle count scan? So just to explain what antral follicle count is, the antral follicles are all the tiny small follicles that we can see on an ultrasound scan of the pelvis, and these small follicles are yet to really be recruited into any future menstrual cycles. So when women are on their period, the next cohort of follicles are actually ready to grow. And when the hormones from the anterior pituitary gland, which is at the bottom of your brain really, start producing two hormones, FSH and LH, they will actually encourage the next cohort of follicles to grow. So it follows that if we've got a high number of follicles in that antral follicle count scan, then if we were to stimulate ovaries during that menstrual cycle, we should be able to encourage a decent number of follicles to grow, and then to give a trigger injection to, followed by an egg collection to be able to then fertilise those eggs to create embryos. So the higher the antral follicle count, essentially it's a surrogate marker of what the ovarian reserve is like, and it gives us a little bit of an indicator as to how many eggs we might be able to collect in any given patient. Now, the question is, what is the best time to have an antral follicle count? I would also always say that in the early follicular phase, so usually roughly any time between day 2 to day 6 would be a decent time to actually perform an antral follicle count. The other test here at TFP that we use to assess for ovarian reserve is anti-Müllerian hormone blood test, shortened to AMH. So AMH, anti-Müllerian hormone, is a hormone that's secreted by all those tiny little follicles before they're ready for recruitment. And also, if we have a nice high number, so anywhere between 15 to 30 picomoles per litre, we expect to find a normal ovarian response if we were to then do an IVF stimulated cycle. In actual fact, when we're doing a first time consultation, the assessment of ovarian reserve usually takes the form of doing that AMH blood test as well as an antral follicle count. And we kind of use both of those variables to discuss with you what we think your egg reserve may well be like and what to expect during a potential IVF treatment cycle. Okay, so let's move on to the next question. The next question is, what is the best cycle protocol for a frozen embryo transfer, so an FET, if you have a large unrepaired C-section scar defect or isthmocele that's causing spotting of old blood until ovulation? And this patient has suggested a natural cycle might be better because it avoids fluid buildup in the lining. I think that's a really specific question, and the way that I would answer this is that in actual fact, with Cesarean scar niches, that's another term that sometimes you'll hear about these Cesarean scar defects, is that if there is a C-section scar niche, if it's causing symptoms, really, we need to think about whether the niche being there is going to impact implantation altogether. So it might not necessarily matter whether we opt for a natural frozen embryo transfer protocol or a medicated frozen embryo transfer protocol. Certainly if a patient is having bleeding mid-cycle and we know on pelvic scanning imaging that there is a Cesarean section scar niche, my advice would actually be to go and see a gynecologist in a gynecological clinic who has the expertise of management of a Cesarean scar niche, rather than proceed on for an embryo transfer, because I would just really worry if there's a large defect in the womb wall at the front where we've actually opened the lower segment of the womb before to deliver a baby. If there's a defect there, I would worry that trying to implant an embryo in that womb may not take. So that would be my initial concern about that very specific situation. So the last thing I wanted to add about caesarean scar niches or isthmoseals is also the fact that they're not all the same. So it really depends on the size and also the symptoms that you're experiencing with regards to how we should manage it. Actually, when you do ultrasound scans on women who've had previous caesarean sections, it's quite common to see a thinner area on the front of the lower part of the womb. However, if the woman is not experiencing any symptoms, then nothing may be required in terms of surgical management. However, if there is a big defect and there are symptoms, sometimes it's necessary to consider some further imaging, perhaps like in the form of an MRI, or even surgical management to try and fix the defect. So the next question I've got here from a patient on social media is, I had an embryo transfer yesterday, but later I experienced diarrhea, excessive sweating and cramps that lasted about 5 minutes. Is this a normal reaction? I'm worried it may have affected my chance of implantation. So I would suggest that it isn't normal to have these symptoms per se. I wouldn't say that it's common for many patients to have an embryo transfer and then get diarrhea, loose stool, and sweating and cramping. What it sounds like is that it may well be that the patient may have well been quite anxious at the time, and us doctors call it having a little bit of a vagal overdrive. So when you feel a little bit nervous, you can feel quite clammy, you can feel quite sweaty, and then you can also have some loose stool as well on your motions. So I would actually suggest that the manifestation of those symptoms is probably because of anxiety for a really nervous time of your fertility treatment. I don't think, though, that those symptoms will have any impact on whether the embryo will implant or not. So from a reassuring perspective, I don't think that having those symptoms will necessarily have changed the outcome of the embryo transfer procedure. Now, of course, if any patient really having fertility treatment is getting more severe symptoms of any sort after an embryo transfer, then I would always encourage them to contact their TFP unit to seek some advice from either the nursing team or the medical team. So the last question I've got here is, do you think we should be focusing more on male fertility? And I would actually strongly agree that we do need to focus more on the male fertility side of investigations. And that's mainly because we know that around 40% of couples who are struggling to conceive may well have an aspect of male fertility. And at the moment, we do tend to focus a lot on female fertility. At the moment, there are not a lot of tests that are available apart from sperm testing and sperm DNA fragmentation testing to identify exactly why sperm counts are low, or morphology or sperm quality is low as well. I think in general, what we can definitely advise though is that lifestyle factors are actually really important in the male partner. So ensuring that you're eating a whole food diet, trying to stick away from ultra processed foods, ensuring that you're getting a good night's sleep each night, and also trying to reduce your exposure really to toxins. So things like cigarette smoke or alcohol or excessive caffeine are all things that all men should be thinking about as well. We also need to consider whether scrotal temperature is raised too high. So we've just been through a winter, and actually lots of people, lots of men may well have been sat on seat heaters in their cars. They may be keen cyclists and spend a lot of time recreationally cycling. And so we do know that when scrotal temperatures do rise, we get problems in terms of the quantity and quality of the sperm produced from the testicles. So apart from doing those lifestyle factors, clearly testing the sperm parameters is a really good first step to trying to understand your sperm health. So if you are worried about infertility and whether there could be male factor infertility there, I would really urge you to go and seek out having a sperm test at potentially one of your TFP clinics around the UK. We need to encourage more awareness and focus on both male and the female partner, and treating patients as a couple if they're presenting as a couple to fertility clinics. So we've covered quite a lot of different topics in this Ask the Expert session, and hopefully some of the questions and advice that have been provided could be useful to you. I just really want to thank the patients who have actually submitted those questions for me to answer. And if you have got any further questions yourselves, then look out for the next Ask the Expert episode.